Yeah, I did say.
Well, again, whatever.
When I got there in 1840, he was still in contact. Yeah, it is. You can make those remember, and you can still remember it for a while.
But you know, that's I just noticed this triangle.
Yeah, I hope that's not right.
Rock on the other way. When I walk on
I got my mic on. I probably ticked off about 5 people already.
Morning. Welcome to the Department of Medicine Grand Rounds. Today we have a special guest. We'll have a very exciting presentation, but before that, a few words. Number one, Dr. Lori Wagner, who's probably watching me from the VA. Oh, I can see that from here. I was just notified won the Educator Award from the School of Medicine, so if you see Lori, please congratulate her. Congratulations, Lori. Number two, for the fans of the Giants, what can I say? Third World Series in 5 years. I'm getting tired of it. That's okay. Now, this day was the birth, back in 1928, of Daniel Nathans. And Daniel Nathans won the Nobel Prize in 1978 for having discovered and implemented with his colleagues restriction enzymes that we now use today to cut DNA, sequence genes, combine different genes into different models. So that was an important discovery. On this day was also the birth back in 1895 of Dickinson W. Richards. And I'll tell you why this was interesting to me, particularly since we're celebrating John Walker Moore. So Richards won the Nobel Prize for Physiology or Medicine in 1956 for heart catheterization and for his work on the circulatory system. Let me repeat that, circulatory system. On this day, back in 1958, was the first angiogram. And it was the first angiogram because Dr. Mason Soames, who was a pediatric cardiologist, made a mistake. In those days, you didn't want to do catheterization and catheterize the coronary arteries because in dogs that caused fibrillation. Cardiologists in the room will know this. But he, not knowingly, when he injected the dye, realized he was in a coronary artery. The patient did not develop fibrillation, and people started realizing it is safe to do so. Why does that relate to John Walker Moore? Well, John Walker Moore was very involved in developing ideas and in testing in his laboratory with Dr. Kinsman, dye injection for the measurement of cardiac output. And that puts all this history together for me. Why do we celebrate John Walker Moore? When I think about the Department of Medicine and the School of Medicine at the University of Louisville, I think of John Walker Moore. He was born in South Carolina in 1884 in a town called McKennelsville. And he obtained his MD at the University of Pennsylvania in 1912. He moved to the University of Louisville in 1917, not realizing that he would spend the next 37, 40 years at this organization. After 2 years in the Army and overseas from 17 to 19, he came back to the University of Louisville as an instructor. And in 1923, was named chairman of the Department of Medicine. Just a few years later, in 1929, he was also named the dean, and he held both posts until he retired in 1949. Now, he was very well known for his efforts as an educator. He was also a researcher, having studied cardiography, basal metabolism, blood chemistry, and of course the dilution method with Dr. Kinsman. But he was best known for being a leader at this organization. He served this organization during the Great Depression. He served the organization during the flood of 1937. He was the first to annex this building at the First and Chestnut Street. He accelerated training for medical students during World War II, and he became the first to engage the state to receive dollars for the School of Medicine in 1948, first to receive appropriations from the state for this organization. So he retired in 1949, and since then we recognize him as one of the leaders of the postmodern era of the University of Louisville, and that's why we celebrate him today. He was also a fellow of the American College of Physicians, so every year we bring somebody who has excelled in the area of academic medicine in the country, somebody who's well known as an educator, a researcher, a teacher, and a master clinician. And today we have that in our speaker, and for that I will bring up to the stage Dr. Neil Roberts, our Chief of Rheumatology.
So today we have a good treat. We have Dr. Oddis from Pitt. Dr. Oddis is one of the people in rheumatology who people call by first name, you know, like Bono or Beyonce or something. And the reason is that he's probably the top person that you can call and talk to as a clinical doctor, and has contributed a huge amount to this area, inflammatory myositis. He's had a huge effort in subsetting with serology and in trials after starting as a regular clinical educator like most of us. So he has R01s and all the other alphabetic soup type grants that have to do with clinical trials in this area. And most recently published one on rituximab, which we may hear a tiny bit about later. And it just as happened in lupus, it didn't work so well. It's the hardest area, other than scleroderma, probably in rheumatology, to get patients better when they're refractory. And that, I think, is the interesting part about this unit at Pittsburgh and Dr. Oddis particularly. There's a kind of a history of intellectual fearlessness that stretches back to Dr. Metzger, who was Dr. Oddis' chief when he was a fellow and stayed there a long time. They really tried to attack the hardest problem, which is scleroderma, without too much thought about where the grants were going to come from and what was going to happen to people's careers and stuff like that. And this effort in myositis that you'll see the outline of during the talk is in that frame, just trying to do the right thing, do the hardest thing, the thing where there's the most need. Dr. Oddis.
Okay, so let me turn this on. When you talk about the path, it's kind of like floundering, is what you said. You didn't say that, but that's what all right. And the thing about Beyonce, I called her Beyonce or something. I did all the accents and the words wrong, and I was hooted and laughed out of my family. So I won't do that stuff, but I'll talk about myself. And it really is a pleasure to be here. That was a great introduction and very interesting history. These are my disclosures. So what I'm going to talk about today is something you may not hear or think about too much, but I kind of weaved a different picture pattern here into demonstrating the systemic nature of an autoimmune illness. But what I will do is provide you some background on myositis classification, the spectrum of autoantibodies, which I think are fascinating in this field. I'll talk about autoimmune ILD, and it's important because it kills my patients with myositis. That's why it's particularly important. And then I'll talk about treatment options if I have time at the end. So, really anything, I always have to put this kind of disclosure qualifier up there that even though I talk about some treatment aspects, none of these are approved for myositis because we are not a big ticket item as rheumatoid arthritis, for example. So just the obligatory definition. First of all, when I talk about idiopathic inflammatory myopathy, I want to really kind of emphasize the systemic nature of this disease, which really kind of begs that term heterogeneity. It is a heterogeneous group of autoimmune syndromes characterized by chronic muscle weakness, constricted muscle, inflammation of unknown cause, but it's way, way more than muscle. And when I talk today, Idiopathic inflammatory myopathy is a bit of a mouthful, so I'm just going to call it myositis, which is what we call it, which you already call it. So we have criteria for this disease. The criteria for inflammatory myopathy: muscle weakness, myositis, symmetric proximal muscle weakness. This is old criteria. It dates back to 1975. So when patients have symmetric proximal weakness, elevated muscle enzymes, a myopathic inflammatory EMG, and a characteristic muscle pathology which demonstrates lymphocytic inflammation or inflammatory cell inflammation, infiltration of muscle tissue, that's four criterion for inflammatory myopathy. And these patients are characterized as having polymyositis, adult polymyositis. Now, when somebody with that pattern of weakness in clinical features shows up with these rashes on their knuckles, over their knees, here, they're called Gottron papules. They can also have a rash that looks like psoriasis. And we've seen patients that have been diagnosed with psoriasis or psoriatic arthritis, and they end up having dermatomyositis. But you can see here that this is a scaly erythematous rash over the elbow. This is called Gottron sign. Doesn't have the papules associated with it. And then there are other rashes. This is a different varieties, different flavors here of what is termed the heliotrope rash. This is an edematous rash, almost looks like eye makeup. This is a rash that almost looks like a raccoon sign of trauma. And then this is much more erythematous and edema, and it's named after this flower called the heliotrope. And the heliotrope likes sunlight, but these patients don't like sunlight because it makes your rash worse. So these are the rashes that we see. When somebody has a rash like that, it's not hard. They're weak, they're proximally weak, their CK's up, they got a myopathic EMG, and they show up. These people have dermatomyositis. And that's why you add this final little tidbit here. Skin rash that we just saw, add that to all these features, and you get dermatomyositis. Or if you're a child, you get juvenile dermatomyositis, and you need to understand that juvenile dermato greatly predominates as opposed to juvenile polymyositis. Well, there's other varieties. So you can look at muscle disease and you can classify it clinically. I'm giving you now a clinical classification of these diseases. You've got adult poly, adult DM, and then you have the juvenile myositis. And you've got these three other categories, which we're going to touch on. Well, some of them we're going to touch on. We're going to talk about this later on with more malignancy-associated myositis. It kind of always comes up. We're going to talk about myositis and overlap and how that can fool you at times. And then there's an entity called, I took out the slides, you just don't have time to do everything anymore, inclusion body myositis. So that's a conventional classification of myositis that we have. Now you can also look at muscle pathologically. So I always throw this question out. DM is simply PM. If you just slap a rash on somebody with PM, that's DM, right? Well, that's actually not the case. So DM just isn't polymyositis and adding the rash to it. And the reason for that, and that's why this pathologic classification comes on board, is that it's different. They're different. You may look at a patient and phenotypically see the exact same muscle weakness that you see in PM and DM. But when you look at these patients, you see that the infiltration and the immunohistochemistry of these two different entities is different. If you kind of look at it as a target, I always look at autoimmune disease as a target. You know, vasculitis target the large vessels, small vessels, lupus targeting certain organs. Well, if you look at the kind of dummy it down and look at the target of polymyositis, it's this lymphocytic, very beautiful picture here of lymphocytes invading a myofiber, but that myofiber is not yet necrotic. And usually it's a CD8 positive T cell invasion. If you look at dermatomyositis, it looks different histologically. And these patients have perivesicular atrophy in their muscle fibers, and they have B cells in terminal complement, as well as endomeseal attack using the CD8 positive T cell. So the target here seems to be more blood vessel as opposed to myofiber. So it's different pathologically. And I put this, I know it's black and white, but I put this up here because it's a really beautiful, put together by a neuromuscular pathologist, Dave Oddis. And these are the four different kind of varieties of myopathy that we're talking about. and on the upper left is the dermato, and you can nicely see by these arrows, this is the middle of the fiber, you can see the plump fibers, and then you see this perifascicular atrophy on the outside. You flip it over to IBM, completely different disease. It isn't just proximal weakness. We're not talking about it, but it's way different. These patients have hypertrophic and then atrophic fibers. You do get inflammation. It sometimes invades fibers, and then you get these vacuoles. These patients, this is a completely different entity affecting older people. And then you get polymyositis, where you have MHC positive, MHC1 reactivity, and then inflammation. And then you get this new entity, which I'm going to talk about at the end, called necrotizing myopathy, where you have a lot of necrosis in the muscle tissue, but no lymphocytic inflammation. I'm going to talk about that again briefly later on. So this is kind of like 4 varieties, looking at it from clinical to pathologic. You can make it a little bit more interesting and then add and expand this clinical classification. And this is an entity, and I know Dr. Keelan is a dermatologist here. He's not here. He actually emailed me. He's not around, but he's had an interest in dermatomyositis, obviously the amyopathic variant of dermatomyositis. And why do I mention that? Because you're going to see that there's a kind of a theme here. So first of all, let's define it. What is amyopathic? Well, obviously you say, well, it's just dermato without muscle involvement. That's correct, but it's a little bit more complicated for a couple of reasons. First of all, it is a subset of DM patients with skin of DM for 6 months or longer. Now, they don't have proximal muscle weakness, but they may have other minor features that kind of implicate muscle involvement. That is, maybe the CK is slightly elevated, maybe the EMG is mildly myopathic, maybe there's minimal biopsy abnormalities, but if you talk to the patient, and if you examine them, and if you test them, they are not weak, okay? So CADM, clinically amyopathic, can be totally amyopathic, or it can be what's called hypomyopathic. That means a couple features, but no weakness. So just keep that in mind when you think about this entity. And why is it important? When you think, okay, clinically amyopathic DM, no problem. You just take care of some of the skin problems and you're good, but you're not good because these patients actually have a frequency of cancer that is actually the same as classic adult dermatomyositis. So when you see these patients with clinically amyopathic DM, you got to think about other problems that can occur in dermatomyositis, and that is cancer. So actually, if you look at the comparison, they're very similar in larger series in terms of the frequency of malignancy. And we used to think that ANA, if it's along for the ride in these patients, it indicates a protective factor. Well, it may not be protective in the malignancy. And then, as I said before, I'm going to come back to cancer and myositis near the end of the talk. But the big one here is that lung problems can occur in patients with clinically amyopathic dermatomyositis. And that's what a lot of us deal with. And unfortunately, it's what a lot of us lose patients to. And if you look at large series, you actually see that maybe 10% of these ADM patients have interstitial lung disease. And the challenge is that the diagnosis of the lung disease may be missed if you don't pick up some of the subtle dermatomyositis features or other subtle connective tissue disease manifestations. And that's what I'm going to spend some time on for the next 10 or 15 minutes, and that is talking about lung disease. But before we go to lung, the skin can be bad. The skin can be, you may think, well, skin, you add a little bit of medications and that'll clear up the skin, and sometimes that's the case, but sometimes these patients are very skin dominant. And this is a guy, in fact, I just saw this guy 2 days ago in follow-up, and I've seen him now for a few years. He's a salesman, and he has dermatomyositis. And you can see here that he's got pretty prominent Gottard sign. He has what's called Shull sign over the back. He's got a rash over the chest that gets worse when he gets sun exposure. And he had a really bad scalp rash and he was itchy. And I kind of gave the clue here. He's a salesman, so he's shaking hands with a lot of people, and he's out there, in the community. And they look at him. He's got a red face, and he's got marks all over his hands. And it's embarrassing for this guy. This is a big deal. But if I go to test this guy and I hold his arms up, I can actually hang off his arms, okay? He's got absolutely no muscle disease. He is only skin. The skin's a problem for this guy. Not only is it a problem because his scalp itches and he feels miserable at times, but he's out there, interacting with people and they wonder what's going on with him because he's quite healthy. This is another example of skin being a problem. This is a lady I saw many years ago, and she's not shown up at the clinic in a long time, but her scalp was so bad that she was seeing psychiatrists and getting incredible intervention because it kept her up at night, the degree of neuritis and pain that she had in her scalp. As you can see, I mentioned earlier, dermato being a vascular target. This looks like vasculitis. This is how some patients with dermatomyositis may actually evolve and present. They can get a pretty bad vasculitic manifestation with necrosis. This is a rash over the anterior chest. This could be a lupus patient, right? With a V-neck rash, but this is a patient with dermatomyositis. You can get cuticular overgrowth, and this is a very nice picture of the capillary changes that you can see in patients because it's a vascular targeted illness. This is the malar rash, and for those in the audience, why is this not lupus? You don't get the nasolabial sparing. Now, why in the world does DM go all the way up to the bridge of the nose and lupus tend to spare the nasolabial? I have no idea. Don't ask me that at the end. This is a patient what's called the Holster sign. I put his hand down here because he's got doctrine changes on his hands, but he's got this rash on the lateral thighs. And then you can, of course, get the V-neck rash that I talked about. This is bad. This is what happens with juvenile dermatomyositis in some instances, where the skin can be very prominent, and you can get calcinosis and this linear extensor erythema. And look at this. This is the degree of vasculitic change that you can see in some patients. This is actually the hamstring musculature in the posterior compartment of the thigh. Just devastating. But the point is, skin can be bad, and for those that have to deal with it in dermatology and even in rheumatology that deal with these cutaneous problems, we end up treating the skin as aggressively as we treat some of the more systemic manifestations. We use common things here, and we use a lot of plaquenil, hydroxychloroquine in patients. But look at this. If these patients don't respond, we're talking about methotrexate, mycophenolate, IVIG, tacrolimus, cyclophosphamide in patients that have really significant skin involvement. So the point that I put up here, and I'll kind of trickle some treatment into this, is that we have to treat these patients pretty aggressively. Now the real interesting part, I talked about classification, talked about clinical, that's how we cut our teeth, looking at things clinically and trying to subset patients. I talked about pathology, but really what's exploded onto the scene in the past several years has really been this autoantibody classification. And I put up this kind of intimidating classification. It used to be that we only had a couple little circles in here. And you could put up scleroderma autoantibody subsets, and you'd have topoisomerase, SCL70, or anti-centromere and other ones, and it's filled with circles. You could put up lupus, where you'd have antiphospholipid, double-stranded DNA, RNP, and now we have a lot of autoantibodies that have been found in patients with myositis. And they're important not only just to populate slides, but they're important clinically. And I'm going to talk about, can't talk about every one of these, but I'm going to talk about some of them. And we just talked about amyopathic dermatomyositis. And I made the case that, you sometimes, we don't have to worry about muscle in these patients, but we sometimes have to worry about skin. And I also mentioned to you that we have to worry about lung. And that's what I'm going to talk about now, because there is actually an antibody called MDA5, which is associated with amyopathic dermatomyositis. I put this up, you say, well, why'd you pick that antibody? And I'm trying to make a case here, because we're going to filter into autoimmune interstitial lung disease now. And I kind of want to make a case that we need to think about ILD in a little different way than perhaps we do. So there's this antibody, and it's called anti-MDA5, and it's CADM140. What that means is that this is where it immunoprecipitates if you look at the serum on these patients and try to identify a band that is concordant with a particular antibody marker. So when I say 140, it's the same as anti-MDA5, but this is just where it shows up on what's called an IP. So these patients were all showing up in the Asian literature. A myopathic DM with rapidly progressive ILD in the Japanese a few years ago. Subacute interstitial pneumonitis in the Chinese population. Other Asian populations. And the target autoantigen. We're big on markers, we're big on autoantigens, obviously, in rheumatology, we're big on autoimmunity. So this target is called MDA5. And what is MDA5? Well, it's a cytoplasmic protein that actually senses viral DNA, induces production of type 1 interferon, and it's involved in the innate immune system against viruses. So, naturally, when you put this all together, you're targeting this molecule in the cytoplasm that has to do with sensing viral DNA. It supports the role of a viral trigger. Some virus, we don't know what it is. That's how we talk about autoimmunity a lot of times. Exogenous antigen, or exogenous factor, environment, infection, comes into a predisposed host, and you get disease. Well, this target autoantigen does kind of support the role of a viral trigger. So this was published a few years ago by Dave Fiorentino in Stanford, where he noticed this cutaneous phenotype with this particular autoantibody. Ulcers, necrosis, palmar papules, severe vasculopathy, kind of like what I talked about earlier. And then this is a follow-up of this anti-MDA5 spectrum that was published last year out of Hopkins, where they looked at a group of patients, and basically they had polyarthritis, they had myopathy, they had interstitial lung disease. This is what I was talking about. This is the band in 140. Sometimes you get other bands. And they talked about these patients having features, which I'm going to talk about in a little while, of the anti-synthetase syndrome. But the point here was that they said that there was no rapidly progressive ILD, so it looked a little different than the Asian population, at least from their perspective. Okay, so kind of fast forward. I see this patient a couple of years ago. This is case 1. This is a guy that actually referred from Chicago to see me. They called me before he was sent, and they said, well, we got this 7-year-old guy, and he had double pneumonia. So, I'm not a pulmonologist, but when I hear double pneumonia, okay, you're just going to have pneumonia, but when I hear double pneumonia, I think autoimmune interstitial lung disease or some other non-infectious problem. Certainly, I'm not going to forget all the other infectious things it can do. But when I hear double pneumonia in my world, I think autoimmune ILD or something else going on besides double pneumonia. So anyway, this guy has double pneumonia in June of 2012. He gets a rash a few months later, vascular skin changes, no muscle weakness, and they call me and says, this guy's in trouble from a pulmonary perspective. And even before I saw him, I said, I think he needs to be treated with cyclophosphamide. So they put him on cyclophosphamide for ILD, and this is what his hands looked like when I saw him. Okay? Now this looks remarkably similar, obviously, to what Dave Fiorentino presented when he talked about this particular autoantibody spectrum of MDA5. So when I see this guy, his lungs are better. He's been on cytoxan for about 2 or 3 months. He had absolutely no muscle disease whatsoever. And remember, he starts off with double pneumonia and percolates on for 3 months, being treated off and on with antibiotics. He's getting worse. Somebody finally notices that he has worsening rash, and then he really gets a bad rash, and he looks like he's got vasculitis. So he gets treated with cytoxan, he gets better, and we had the opportunity to check for the antibody, and he's anti-MDA5 positive. So this is a guy that actually did have bad lung disease in association with MDA5, which is a little bit contradicting what the Hopkins American cohort talked about. Second case, real case. These are all real cases. Lady in the summer 2012 gets a photosensitive rash. In January, she gets polyarthritis. She gets mild muscle weakness. She gets a rash called dermato. She has negative autoantibodies. Look here, negative Jo1, negative ANA, no SSA-SSB. She gets better on a little bit of prednisone and methotrexate. She gets referred to me from Erie, Pennsylvania. And I see her for the first time, a little over a year ago. And I see her in May. Now notice the dates here. She gets her first visit. She's got classic DM rashes. And I'm talking to her and her husband, great lady, and I put my stethoscope on her chest, and I hear a couple crackles at the base. No respiratory symptoms. A little bit of muscle weakness, mostly skin. And I say, well, I think we ought to bump your cell sept and add a little bit of prednisone to try to cool your skin down. Her muscle really wasn't a problem. She had minor joint pains at that time. I said, just do me a favor, I really need to have you, and I talked to the doctor, I said, make sure she gets an HRCT and some PFTs. So again, this is May 2013. So she gets them about a month later, in early June, and she's not really symptomatic, but this is not normal. And I know enough that this CT scan is not normal. It's not horrendous, but she's got patchy changes in her lungs. And this is on June 6th. Well, on July 1st, I'm actually giving grand rounds at Cleveland Clinic, and I got a call from the fellow who we trained, and he's treating her at Erie. He says, this lady this is 3 weeks, so she got really sick. She's feeling really short of breath. She gets a chest x-ray, and they reported her as opacified at the outside hospital. In one day, she's up to 12 liters per minute. And then so I get contacted, and I said, look, you got to jump all over this lady. I don't think it's an infection. I think she's got something going on in her lungs. And we actually pulsed her for cytoxin and started her on rituximab. And I said, what's going on? And she had any skin? She goes, yeah, she's got these things on her palms, too. That we don't see much. It doesn't look like a bad scar. But anyway, she's got these changes on her palms. And this was her CT scan. And that was her CT scan 3 weeks earlier. And she was dead in 3 days because she just had rapidly progressive interstitial lung disease. And she was FDA 5 positive. Now, you can't get this commercially, but we can order this. We actually had a collaboration with the Japanese investigators, Shinji Sato, and we actually saved her serum and checked it, and she was MDA 5 positive. And this is the rapidity. This is what not only kills my patients, but also keeps me up at night, because I get these calls all over the place of patients that have rapidly progressive lung problems in association with relatively minor other problems. So, the MDA5 spectrum, I don't think it's as benign as was reported last year. I think the American population probably has that same rapidly progressive phenotype that occurs in the Asian literature. Now, this is a third case, again, a real case. So now you've got this really weird antibody in association with lung disease. Now, this is a lady that hopefully some of you would recognize this scenario. Again, 52-year-old lady has the OA. In November 2013, a year ago, she gets dyspnea and a low-grade fever seen by her PCP, polyarthritis, weakness, Raynaud phenomena. She shows up and she says, I still don't feel well. A couple months later, she's got acrocyanosis of her fingers, low pulse ox. She gets admitted to the hospital. Negative ANA. I'm going to come back to that. Negative ANA. The CK slightly elevated. Astute rheumatologist sees her and says, well, I think I know what you have, putting together the whole picture because she was treated as pneumonia. Okay? This wasn't put together in a nice picture. She gets an open lung biopsy. Shortly thereafter, shows an SIP, a non-specific interstitial pneumonitis, after the infiltrates and ground glass opacities were noted. And the rheumatology consultant says, okay, we're not treating you with antibiotics. We're giving you steroids, and we're going to start you on Celsip. She was not intubated. Now, what antibody might she have? Well, she's Jo-1. Now, this is more common. This is an MDA5. You need to know about Jo-1. I don't care if you're a rheumatologist, you should know about it, but if you're an internist and a pulmonologist, you got to know about Jo-1. So, this is the anti-synthetase syndrome. All right? Now, who here has heard of anti-synthetase syndrome? Okay. You know about anti-synthetase syndrome. All right, so this defines a clinically homogeneous patient population. And this is the features. And this is an example of what the features are. So, these patients don't have the Palmer papules. They have what are called, I know the name of this? It's called mechanic's hands. Why? Because it looks like a mechanic. I also have a Jo-1 patient who's a mechanic. He goes, did you name that after me? I said, you have mechanic's hands, which no, it's not saying that. But this is mechanic's hands. This is a deforming arthropathy that can occur in some Jo-1 patients. This is Raynaud. Another fellow put this in there for me. That's fever. I know, I'm good at that. This is ILD. So this is a syndrome, a unified syndrome of multiple manifestations that these patients often present with. And sometimes when they present with every one of them, it's easy. But the skin rash and the myositis may be very subtle. In other words, they may not have classic Raynaud and a little bit of rash and Raynaud, and all the other features. They may be more subtle. And that's the point that I make whenever I say that you've got to keep your eyes and ears open for these patients, because they may be really lung dominant, is what we call it. Because not everyone's going to present with a classic anti-synthetase feature. So what I'm going to talk about now is making the diagnosis of autoimmune interstitial lung disease. And that's the title of that slide, and I'm going to change the title a little bit later. So let's go back to that big autoantibody spectrum picture that I showed earlier, and let's talk about these anti-synthetases. Now, Jo-1's has a bigger circle in there because it's the most common one, okay? But there are now 8 different. That's fascinating. I mean, why in the world are you targeting an amino-acyl tRNA synthetase in your blood? But anyway, these patients have this entity now has 8 different targets of tRNA synthetases, with Jo-1 being the predominant one. You know, it's common. 20 to 30% of our myositis patients have Jo-1. Well, I'm going to make the case, and you're going to say, well, these are just weird antibodies that you see occasionally in Pittsburgh. No. This isn't a cohort of 20 patients. This is a cohort we have now over the past 20 plus years of 229 synthetase positive patients. That's a lot of patients, okay? That have, a lot of them are just local, referral. Some of them are referred from outside for sure. But what we have now is, in this cohort, this was up until a couple of years ago, a very large cohort. And if you break it down, which I always was curious about, you break it down, you call the Jo-1s and the non-Jo-1. Now, this isn't all other antibodies. These are just the anti-synthetase cohort. So we did that, and we looked at these patients, and I think it's very instructive. So we looked at these 2 groups of patients, and we broke them down into Jo-1 and non-Jo-1. Now, this is a busy slide, but just give me a minute with it. So this is the Jo-1 cohort, 120 patients. Again, I said this isn't just a little case series. And then we've got these other that I grouped together, the other anti-synthetases. And they look different. And I knew they looked different over time. So I said, we've got to look at this more carefully. And when we looked at it more carefully, we actually just published this a few months ago in the Annals of Rheumatic Disease. We've got this large Jo-1 cohort over here. What do they have? So I put initial connective tissue disease symptom. That is, what do they show up with when you see these patients? Well, they show up with Raynaud's, as you would expect, but less than the non-Jo-1 cohort. Muscle, they have more muscle. Less muscle over here. Joint, higher over here. Pulmonary, they both get pulmonary. So the point here is that Raynaud is more common in the non-Jo-1 subset. Muscle and joint is less frequent in the non-Jo-1 subset. So that's just what they show up with, okay? Because that's how we make the diagnosis, right? Well, then what's their first diagnosis? Not what the symptom is, but what do they get diagnosed with? And this is where it's interesting, too. Look at the Jo-1 cohort. Myositis is diagnosed as their initial diagnosis in, the great majority of patients. Non-Jo-1 subset, only 40% have myositis. Half have what are called undifferentiated connective tissue disease or overlap. That means we don't know what you have, but you got something that's autoimmune, okay? And then even scleroderma shows up in this non-Jo-1 cohort. Now, these are called myositis-specific antibodies, but they are far from myositis-specific. I've always had a problem with that. So here's this overlap. Here's this Jo-1, non-Jo-1 cohort, big cohort, and they're looking different, but they're all part of the same target in terms of targeting an anti-synthetase. Now, why is that? What case am I trying to make there? Well, first of all, the survival is different in this cohort. And you can see here that the Jo-1s get diagnosed earlier, but the non-Jo-1s, why? Because they're kind of undifferentiated, they get diagnosed later. They get diagnosed later, and they die sooner. So the survival is significantly different in this cohort over this time period, in this Kaplan-Meier curve. Okay, so there is a survival difference, being worse in the non-Jo-1 compared to the Jo-1. But how are they dying? They're dying pulmonary deaths. Okay, 60% of these patients die of pulmonary death. Even some of these over here have lung problems. They just don't die of pulmonary disease. They're dying of fibrosis and they're dying of pulmonary hypertension. Now, pulmonary hypertension, just secondary to the fibrosis? This is primary pulmonary hypertension concept, not hypoxemic vasoconstriction due to the pulmonary fibrosis, but they're dying of what some of the scleroderma patients die from when they have primary pulmonary hypertension. So again, the cause of death is pulmonary, but they get it in a different way. So I changed the title. How do you miss autoimmune interstitial lung disease? Or maybe you call it IPF, or maybe you call it something else. Well, you miss it because you don't recognize these incomplete clinical syndromes, all right, in the setting of pulmonary disease. And you call it pneumonia, or you call it IPF. And maybe they have a very subtle rash that goes away when you give steroid or something else. Or maybe they have this undifferentiated connective tissue disease, and you're not clued into asking about inflammatory arthritis, Raynaud phenomena, and other features. So that's how you miss it, okay? Well, and you miss it because we have this entity, at least in rheumatology, you don't appreciate it as much in general medicine, where you get these myositis-specific antibodies out there, and they really, you can't order these. They're hard to order. They're not always accurate commercially, okay? You can't just go to your hospital and say, okay, I want an MDA5 antibody. You can get a myositis panel, and that might show you a lot of the synthetases, but some of those aren't accurately really vetted out in terms of truly being, Joe 1 is accurate. You order a Joe 1, you're going to get it. But maybe the PL7 or the PL12 or some of those other synthetases really aren't accurate out there. And certainly, you're not able to really order this on a confident basis, the anti-MDA5. So that's how you might miss it as well. Not only do you not pick up features, but you really can't diagnose it by looking at the autoantibodies that you'd like to find. And then the third reason, I'm going to go back to our case 3. I told you she had a negative ANA, right? Now she ended up having Joe 1, and that was ordered and that was picked up. But let me just talk about the Joe 1. So what do we know about Joe 1? Well, I told you before it's directed against histidyl tRNA synthetase. Now, where is histidyl tRNA synthetase live? In the nucleus? No. Yeah, it's a cytoplasm. You don't make protein in the nucleus, right? So the antigen is an enzyme that catalyzes the binding of an amino acid to the cognate tRNA in the process of protein synthesis. So this is the target, some enzyme that's all over the place, and you're targeting it. Go figure that one out. And it's in the cytoplasm. Okay? So a negative ANA does not imply autoantibody negativity. Okay? And this patient had a negative ANA. And maybe a lot of patients have a negative ANA, and you'll be reassured. They get this homogeneous diffuse cytoplasmic staining. Notice the nucleus is clean. So we figured we'd study that too, to kind of make it. We haven't published this yet. This was an abstract form. So we looked at that same cohort. Again, we had about 200 patients, and we found that only a half of the synthetase positive group had a positive ANA. And 3/4 had cytoplasmic staining, and there was a significant difference. And this is in looking at immunofluorescence in the lab on these patients. Well, we broke it down, and the Joe 1, non-Joe 1, not much different. The point here is that there is a difference between ANA and cytoplasmic staining. But let's throw up another disease. Throw up scleroderma. 100%, 99% of patients with scleroderma have a positive ANA. Okay? And very few have cytoplasmic staining. So there's a difference right there. And that is that maybe in some of these patients that show up in the community hospital or our own hospitals, and they don't have all the classic features of an antisynthetase syndrome, and then you get antibodies and the rheumatoid factor is negative, and the ANA is negative, and maybe a lot of the other routine antibodies are negative, and you say, well, this probably isn't autoimmune. And I'm making the case that don't be reassured by the negative ANA, because that negative ANA may still indicate autoantibody positivity that you're just not detecting. So these are the points that, that's my little kind of exit there into autoimmune ILD, all right? Because I think it's really important as internists for us to realize that. Now there are other autoantibodies. MI2 and TIP1 gamma, I told you I'd come back to that, so I just kind of want to summarize that in the slide. I talked about the first two already, all right? CADM140 and JO1. MI2 has a Schall sign. This has the V-neck. These patients have dermato, and they actually have a positive ANA. So not all of these myositis antibodies have a propensity to have a negative ANA, because MI2, for the most part, it targets a nuclear helicase. It's a positive ANA. Well, in myositis, or in rheumatology, we sometimes struggle with this, and you probably know about the frequency or the increased frequency of cancer in association with dermatomyositis. So we thought, okay, are there autoantibody markers that identify patients with malignancy associated with myositis? Because you want to know that. It'd be nice to have a marker. You know, you're going to pick up dermato, you're going to pick up the disease, and it would be nice to know that subset that have an increased chance of cancer. And indeed, it's been reported over the past few years that this antibody marker called TIF1 gamma, transcription intermediary factor 1 gamma, these patients have this doublet on that immunoprecipitation that I talked about. You can see this doublet here. They have DM, they have JDM. We'll get back to that in a minute. And they have severe skin, and they can have this frequency or increased frequency of cancer. So what do we know about this antibody? And I just put up some things in adults. It seems to be associated with bad skin and cancer. But kids with JDM don't get cancer, and they have that exact same autoantibody. So, and actually, it's one of the most common autoantibodies in juvenile dermatomyositis, is TIF1 gamma. 25–30% of these kids have it. They don't get cancer. But cancer, as I said, not seen, and you don't see this antibody in PM or overlaps. So it seems to be a DM-specific autoantibody. So a few years ago, we were involved in this study. We collaborated with Hector Chenoy from Britain, and he looked at his cohort. I'm just going to go through this quickly. The bottom line is that in his UK cohort, it seemed to be that the antibody against this doublet, this TIF1 gamma, represented a significant risk for cancer. But we were checking this too, and we were not seeing patients that had this antibody who always had cancer. So we asked ourselves, and so we said, is there something different about the titer of the antibody that makes a difference? So Rohit Agarwal, who works with me closely, developed this ELISA. I'm not going to go through that. And then he looked at this ELISA. He looked at a bunch of patients that we see. We looked at healthies, Joe-1s, RA, scleroderma, lupus, and then here's our myositis group. And you can see, obviously, that these patients have positivity for this antibody, but they don't all have cancer. So then we took it a step further and said, the quantitative TIF1 ELISA titers actually predict cancer. And this is where it's interesting, and this is unpublished. So this is not peer-reviewed, but I thought I would put it in here. So this is not published. But we did present it in an abstract form, and what we found was, we looked at the titer of the antibody. This is a TIF1 negative group, and this is cancer in the x-axis, or y-axis. And in the low positive and the negative, there's not much difference. But when you go to this high titer of this antibody, you actually see a significant increase in frequency. So this is, again, preliminary, but I think it's very interesting that this may actually, at least not explain, but it may actually, if you could actually look at the titers of these antibodies, it may actually make some difference in patients with DM and cancer. So, just some take-home points on this subset. Risk greater for DM and cancer. Malignancy types are not that much different than you see in the kind of the age-specific group. ILD overlap and another myositis antibody really decreases the likelihood of cancer. So those JO1 and other synthetase positive patients, they're not likely to get cancer. Okay, and then just a couple of things in terms of staying tuned for the TIF1 ELISA. Well, there are other antibodies. I told you I'd come back to the necrotizing myopathy subset because that's two things that are important. Number one, when we talk about another autoantibody called anti-SRP, signal recognition particle, again, another fascinating antibody. No DM, this is PM, quote PM, but these patients have that biopsy picture that I showed earlier. No inflammation, necrosis. Well, there's one other piece of the puzzle that we're adding to it now, and that is this necrotizing myopathy. Now, the anti-SRP subset is interesting. Like I said, they have severe weakness, they have necrotizing, they have a poor response to therapy, they almost look like they have a muscular dystrophy. That's how bad a myopathy can be in these patients with SRP. And this is the pathology I talked about earlier. Necrosis, 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 atrophy, no inflammation. No inflammation. Very interesting. One other thing came up, and that is I started to see patients that had this necrotizing myopathy, but they didn't have SRP, but they were taking a statin. And then this whole thing emerged over the past couple of years where this statin myopathy came up. So I want to take a couple of slides just to talk about this because it's relevant to the interest. Immune-mediated necrotizing myopathy, IMNM, associated with statins. So I was having these patients that had this necrotizing myopathy. They didn't have anything else. They didn't have dermato. They didn't have polyarthritis. They didn't have extramuscular features. They had this necrotizing myopathy. And I couldn't characterize them very well. But I noticed that they got better with immunosuppressive therapy, much like I treat polymyositis. So they had proximal weakness. So again, this was reported, and I said, well, this really makes sense 5 years ago, because this is what I'm seeing. Proximal weakness, elevated CK, persistent weakness despite stopping the statin. Get better with immunosuppressive agents, and you get a necrotizing myopathy without inflammation. And this is what they reported a few years ago. Now, this wasn't a couple of patients. This was 25 patients from the Harvard Consortium, Harvard hospitals, from 2 different centers. 24 of those 25 patients required immune suppressive therapy. 15 relapsed. So they acted like autoimmune muscle disease. And this, you can see here the features that I'm talking about. So the lack of improvement following stopping a statin. You stop the statin, and you still get disease. It doesn't go away. So it really acts like that concept of a trigger in a predisposed host, and you get autoimmune myositis. Well, it got a little bit more interesting that same year when the Hopkins cohort published the same type of thing. I'm not going to go through this, but what the Hopkins people found was an autoantibody. And they found an autoantibody against a 200-100 doublet in their patients. All their patients were weak. Only 2/3 had a statin, but if you look over the age of 50, most of these patients were exposed to a statin. So it was the same kind of cohort. Responsive to, reactive to a statin, get a necrotizing myopathy, get inflammation, and they get better with immunosuppressive therapy. And to cut to the chase, they actually identified the target being, which you know, HMG-CoA reductase. So the antibody in this statin myopathy is against HMG-CoA reductase, which is, the antibody or the enzyme that is inhibited by the statin. So now you've got 2 entities in there with necrotizing myopathy. You've got an SRP, and you've got statin myopathy, and there's an antibody associated with the statin myopathy. So there it is there. And you can actually order this now. Remember, in your patients on statins, I gave a lecture last week on statin myopathy, and a lot of patients have myalgias. We're not talking about myalgias. We're not talking about a CK of 300 or 400. We're talking about a real significant weakness in patients with a markedly elevated CK. So, but the point is that you can actually order this commercially through RDL now to look at that antibody. Do I have 5 minutes or should I stop?
You have it.
Okay. So just a little bit of treatment in these patients, and I'll bring back ILD. And most rheumatologists know how to use steroids and methotrexate, so I kind of looked at a little. This isn't meant for you to read, but the point here is that this is what we have to deal with in myositis: case series, case reports, all this kind of stuff. All right. So we don't have a whole lot of data out there. But we struggle with these patients because we've got to treat their muscle, and we've got to treat their skin, and sometimes we have to treat their joints, and we have to treat their lungs. So these are tough patients. I often say that myositis is more systemic than lupus, just to annoy the lupus people. But the point is that we have a lot of challenges in treating our patients. So the combination therapy is important in myositis. And you know how to use steroids. Most of the rheumatologists, know how to use methotrexate, but sometimes a combination of methotrexate and Imuran can be beneficial, and sometimes even the combination of methotrexate and Cellcept can be beneficial. So remember this combination therapy in myositis. And if we go beyond that, mycophenolate. What about mycophenolate? It's being used more and more in lupus and our other diseases. And we have seen that these are small series. This isn't big time series. And using the same doses in lupus, we see that dermato gets better. And another example of dermato getting better, if you add IVIG onto MMF, patients get better. And it's actually used in juvenile dermatomyositis. So there's emerging literature of using CellCept in patients with myositis. What about ILD? This is what we struggle with. And there's lots of anecdotal stuff. And obviously patients get steroids and they get pulsed. And then they get cyclophosphamide, and we know that it works. And you can give cyclophosphamide orally. You can give it in a sequential monthly fashion. And there is now more data, even recently, on using CellCept in interstitial lung disease in patients with not only myositis-associated ILD, but any connective tissue disease-associated ILD. So you've got more, arrows there to shoot with. And then there's data on using cyclosporin and tacrolimus. What's that all about? Obviously these are anti-transplant or anti-rejection drugs. So the question then comes up, is anti-T cell therapy rational in patients with myositis-associated ILD? We know that steroids work and Cytoxan, but why tacrolimus? We published on this, and I took the slides out. But why tacrolimus? Why does it make sense? Well, if you actually look at some old literature, it does make sense. Because pathologically, and this is using T cells as therapeutic targets, pathologically, you get these germinal centers and you get these lymphoid follicles in patients with myositis-associated ILD. And you get these infiltrating lymphocytes that are activated CD8 positive T cells. And that was reported years ago. And then these CD8 positive activated T cells are actually increased in the bronchoalveolar lavage fluid of patients with myositis. And you actually get a decrease in regulatory T cells, which are good things in CTD-ILD. So all of this implicates activated T cells as being important targets in patients with autoimmune lung disease. So it does make sense to use cyclosporin and tacrolimus because they predominantly target the T cell. And there is now, after we reported this back in 2005, this is a fellow that worked with me, where we had 13 synthetase positive patients where we had a very nice response to tacrolimus. Not only did it make their lung better, but it made their even their joints and their muscle better as well. And then all these other studies over the years have used anti-T cell therapy, which kind of begs the question of using abatacept, which is an anti-T cell agent that's approved for RA, whether that should be studied in autoimmune interstitial lung disease. You can't read that. That's just an approach to ILD. I haven't been able to put that into a different slide. We just published that in an article. But the point is that it's kind of like an algorithmic approach because these patients are really tough to treat and deal with. IVIG is another medication that we use, and I thought I would, this is studied in a double-blind fashion, and you can't read that, but I thought I would put over here just when you use IVIG. IVIG is pretty good whenever you need steroid-sparing effect in a patient with infection because it's not immunosuppressive, it's immunomodulatory. Okay? It's also pretty good for esophageal involvement where you have a lot of pharyngeal myopathy. And then it's pretty good when you have acute complications of a rapidly progressive process, and it's really good for the refractory rash in patients. So this is kind of like my indications for IVIG. Now there are biologic targets, and if I don't know, do I have 3 minutes to finish up? Is that okay?
Sure.
I mean, you can cut me off if you want. It's okay. But looking at biologic targets, this is obviously a hot area in rheumatology where we've got all these monoclonal antibodies that target things. Well, you would think that TNF-alpha works, but it really doesn't work. So we looked at the B cell target. There's a lot of data on rituximab in an anecdotal fashion. Sometimes it's pretty good for anti-synthetase, refractory DM, ineffective for the rash and some. So we did a large study, and I only have one slide on it because we're going to talk about this later on. We looked at rituximab as the first NIH-funded trial. We studied 200 patients with rituximab, and the endpoints weren't met. We actually included 50 JDM patients in there. But 83% of these refractory patients met our definition of improvement with B-cell depletion therapy. There was steroid sparing in that group, and it was pretty well tolerated. We just published that last year. So that's another option. And this is another hot area, is the type 1 interferon signature being revved up in lupus. Well, it's also revved up in dermatomyositis. And this just shows here that in DM you get these signature genes for interferon that are elevated and kind of turned on. And if you look at these genes, you can actually correlate. Not only is the target turned on, but the target of interferon actually correlates with disease activity. And we took it a step further and kind of combined looking at interferon and IL-6. And this is the last couple slides where we looked at the interferon signature and IL-6, and actually did this through Ann Reed at the Mayo Clinic. And not only did we find that the interferon was expressed, but the ELISA-based interferon chemokines were also elevated, as was IL-6. It also correlated, the elevated transcripts correlated with the proteins in the blood, and then finally, all of this correlated with disease activity. So it kind of gives you another target. There are anti-interferons out there, and there's anti-IL-6 out there, and for that reason, we're looking at anti-IL-6 in another clinical trial because it suggested dysregulation of the interferon signaling, and IL-6 may contribute to the pathogenesis. There's also a mouse model that they actually treated with tocilizumab, and tocilizumab is out there for RA. So the point is that we're using another medication that's approved for an autoimmune disease and looking at it in refractory PM and DM. So that's kind of like a whirlwind tour of myositis. I want to just make the point that it is heterogeneous. Autoantibodies help. Lung disease is a big factor. It's kind of exciting from a therapeutic standpoint, but these drugs also have their share of problems. So I don't know if we have too much over it. If we have time, I can answer questions.
We're seeing a tremendous number of connective tissue-related interstitial lung disease in our clinic, and even the area of IPF, there's a lot of emerging data indicating autoimmunity as well. In fact, one of the reasons we wanted the recruitment of rheumatologists here, so we didn't have to deal with these antibodies, so we can call these people. And one of the reasons is I struggle personally with understanding these antibodies, particularly the link with pathogenesis. So this example you made about statin was probably the best example I've seen about an antibody that links to a clear pathogenetic mechanism of disease. But in the other ones, I struggle with that. Yeah. So tell me more about that.
Yeah, okay. I figured that question would come up. Okay. So these are really interesting, and I don't have time to go through this, but so here you have this synthetase, all right? There's billions of copies of that running around in your blood right now. So what in the world is an antibody targeting something that's ubiquitous, right? Well, it was determined a few years ago by Wakasugi and Schimmel. One of them won the Nobel Prize, by the way. I can't remember which one. But the tyrosyltyrosine synthetase actually has extensive homology with a cytokine. So here you have this ubiquitous enzyme, this synthetase, and in the process of apoptosis of cells, they break down and they become cytokines. So a synthetase becomes a cytokine. So why is that pathogenetically linked? Well, so when you get these synthetases, what might you postulate? I mean, I want to kind of go right to the chase here. So why might it be important? You get a virus. We talked about viruses already. Viruses damages a muscle, right? The muscle releases a synthetase. Well, when that synthetase is released, which is normal and functional enzyme, they act as cytokines. And these cytokines can then actually really turn into different Jekyll and Hyde, all right? The Incredible Hulk synthetase, where these synthetases then recruit mononuclear cells that actually induce innate and adaptive immune responses. So you can get perpetuation of myositis, but maybe also, as that synthetase changes conformation, they actually act as an antigenic trigger for autoantibody response, and this has actually been reported and published in the literature years ago. So that might answer a question, that why in the world would these, well, what do they mean? Are they just little rheumatology play toys, where we like to pretend we know what's going on? and get all these antibodies. Well, the fact that you've got 8% of the patient's target means that there's something going on with this complex. And this here actually postulates a reason why some trigger changes it, and it becomes an antigenic target that not only is antigenic, but also can perpetuate an inflammatory process.
Fascinating. Questions? Yes, sir.
Have you looked at bacteria or animal or plant viruses in the microbiota as possible sources of autoimmunity through molecular mimicry?
Yeah, that's a great question. The microbiome is not really looked at carefully. But you know, when they've looked at muscle biopsies, they really haven't found any infectious viral or bacterial origin or evidence that there's any process. But as far as the microbiome being looked at carefully, no, it really hasn't. But I suspect that it's important.
It's very easy to do a blast search with your target protein and look to see what proteins there are in the bacterial or viral world that might be similar.
Yeah, that's a fact. I don't know if anybody's looking at that as they are in spondyloarthritis or other diseases.
Last question.
Okay, so it doesn't look like there's really a resident immune system in the muscle, right? There's no resident, you have T cells and.
Oh, there actually is. There actually is. It's amazing, and that Nagaraju has done a lot of work. But the muscle has a capacity to act as a little immune factory. Yes.
Well, that was the question. Can the myocytes actually begin expressing other factors such as the IP10, the MCP1, MCP2?
Yes.
Those are all macrophage chemotactic factors. So, do they express any, innate receptor molecules like NOD1, NOD2, things that are, CARD15, those types of things?
I'm a little out of my element when I talk about all the aspects of it, but I can tell you right now that what also has emerged over the past 4 to 5 years is this whole concept of the muscle acting as a little immune factory in itself, and that it can very much express all of these factors that really can perpetuate the immune process. Here is good evidence for that.
Dr. Oddis, we give great speakers a bat. It is a bat that sort of
So cool.
reminds you of Louisville, the Louisville Slugger.
Yes.
And this one says, Chester Oddis, MD, 2014 J.W. Moore Lecture, University of Louisville, October 30th, 2014. So we really appreciate you coming. We look forward for the next lecture. Is that at noon? As well.
It's actually at the VA
And
in 10 minutes.
I couldn't use a curveball. I don't know why I stopped playing ball.
I don't know how they treat you in Pittsburgh. We usually recommend having this close to the door, so that people know what they're about.
I got a lot of use for that.
Thank you so much.
Thank you very much.